So a lot of my research focuses on evaluating antibiotic exposure-response relationship in patients. And one of the things we have come to learn over the past 20 to 30 years is what we do during that first 24 to 48 hour period is critical for subsequent patient outcomes. So you think about it, how long can a patient survive and persist in the absence of effective antibiotics, whether it be in the bloodstream or lung? So one of the things that's really preventing us from delivering early appropriate therapy is antibiotic resistance. And the latest resistant phenotype that's being observed throughout the world is Carbapenem-resistant Enterobacteriaceae. So at one point in time, carbapenems were resilient against E. coli, Klebsiella. However, we have seen compromises in its activity against these pathogens. So again, in terms of thinking about Carbapenem-resistant Enterobacteriaceae, when someone has an infection, you typically don't get antibiotic culture and susceptibility results till 2 to 3 days later. So kind of cognizant of that, one of the important things we need to figure out is who has this at infection onset. So that was really the genesis of this paper, is really to identify patients with Enterobacteriaceae infections who have carbapenem resistance, with the hope of identifying risk factors so we can deliver early appropriate therapy in those individuals with a drug that would be active against CRE. A bug will always find a way to survive and persist. So under constant antibiotic pressures, we see emergence of drug resistance. At one point, almost all E. coli's were susceptible to penicillin. With penicillin use, we saw penicillin resistance. We developed cephalosporins. We saw cephalosporins resistance. We began to use carbapenems, and understandably, we begin to see carbapenem resistance as well. So this is to be expected. It's just a consequence of antibiotic use. So one of the biggest things, in terms of staying ahead of the resistance curve is get it right the first time. Treat infections appropriately, and understand when we need to use different agents than our traditional empiric therapy choices. So when we think about patients at risk for antibiotic resistance, whether it be carbapenem resistance or cephalosporin resistance, there's usually two major drivers. Time at risk in healthcare facilities. You have to be in an environment, where there's resistant pathogens. And probably one of the biggest drivers of developing antibiotic-resistant infection in these settings is prior antibiotic exposure. So what you find is when you receive an antibiotic, it wipes out your normal flora and makes you prone for colonization with a resistant organism. And so when you have colonization with a resistant organism, this leads to a subsequent infection in some individuals. So again, we think about carbapenem resistance, our hypothesis was multiple prior antibiotic exposures would lead to a higher risk of carbapenem resistance among patients with invasive Enterobacteriaceae infections. And our hypothesis was consistent with the data. So the nice thing about this project here is we had access to over 160 hospitals. So this was part of the premier research database, which consists of both academic and community hospitals throughout the United States. When designing our study, we restricted the analysis to people who developed a hospital-onset Enterobacteriaceae infection. When we think about that, and the reason for this was quite simple. With the premier database, you don't really have a lot of information about the patient prior to their hospitalization. Most of the information is during their hospitalization, and because of that, we wanted to really look at patients who developed Enterobacteriaceae infection within the hospitalization to determine risk factors. So we really kind of focused the study to maximize internal validity where we had the most data. I think the one nice thing about our data relative to others, I think a lot of people have kind of identified risk factors in a qualitative way. And what I mean by that, they'll say patients had a prior antibiotic, they've been in a hospital or a nursing home. Really what we did is we developed a predictive algorithm. And really what we did is, based on the number of risk factors present, we quantified the risk of carbapenem resistance. And really what we found is in institutions with carbapenem resistance rates in excess of 2% among all Enterobacteriaceae, when you have 4 or 5 prior antibiotic exposures with gram-negative activity, your risk of carbapenem resistance exceeds 15 to 20%. And it's really at that threshold when you begin to think about alternative therapies besides a carbapenem for empiric treatment. I think the one thing that's very important here is to get folks to realize, the unmet medical need with carbapenem-resistant Enterobacteriaceae. And I think while we're doing a good job with this within the infectious disease community, I don't think people, outside our community are aware of the emerging resistance rates of carbapenems among Enterobacteriaceae. Enterobacteriaceae, whether it be E. coli or Klebsiella, are the predominant causes of gram-negative infections, whether it be in the bloodstream, lung, or urine. So again, these are common infections. We're seeing resistance to what are considered last-line agents. So hopefully this data will provide some heightened awareness and also get the people to think about when they select antibiotics to do some risk stratification to consider the likelihood of a resistant pathogen. Clearly the next step is always to publish, and so we're going to do a little bit more modeling work to figure out if there's other risk factors. We found a very strong relationship between number of prior antibiotics and Carbapenem resistance. So the first thing to see is there any other variables? Does dialysis augment this risk? Does coming from a nursing home even put them at an increased risk? And, but ultimately what our thought is, how do we operationalize this? So the one thing we want to do is not only have a publication, but something that we can maybe give the providers as a risk stratification tool. So that's something we're planning for 2016, because I think we're doing a very good job at understanding risk factors and outcomes. But given that it's the 21st century, I think we have to figure out ways of operationalizing our findings in clinical practice. And again, it all goes back to antibiotic stewardship. The fundamental pillar of antibiotic stewardship is getting it right the first time. And we want to provide a tool to help people identify individuals at risk for Carbapenem-resistant Enterobacteriaceae so they can make more prudent and appropriate empiric antibiotic decisions.